Welcome to the Food Junkies Podcast. Here, we aim to bring you the experience, strength, and hope of professionals working on the front lines in the field of food addiction. Our mission is to educate you, the listener, and increase overall awareness about food addiction as a recognized disorder. Here, we discuss all things recovery, exploring the many pathways people take towards abstinence in order to achieve a health-forward lifestyle. We hope to inspire you to thrive rather than just survive. So stay positive, make a change for yourself, and share your journey with others. And hopefully the message will spread.
How can we use the concept of meta-inflammation to help us with our food cravings and food addiction? Welcome to the Food Junkies Podcast. My name is Dr. Vera Tarman, and I am your co-host today, along with Molly Painschab. Today, we are talking with Dr. Gurpreet Singh Padda, Part 2 discussion, exploring how understanding meta-inflammation and its role in chronic pain, obesity, and addiction can guide us to more effective treatment. Dr. Padda, just to remind you, holds board certifications in anesthesiology, interventional pain, addiction, obesity, and chronic pain, and metabolic health. This is a summary. In part 1 of this podcast, we discussed how the current food environment is characterized by too much processed food that is engineered to be hyperpalatable and thus trigger excessive dopamine release. We at Food Junkies already know that, but Dr. Padda has gone further to explain that the excess overconsumption of fructose and seed oils leads to a state of chronic low-grade inflammation across multiple body systems known as meta-inflammation. This concept of meta-inflammation is critical to understanding how the gut biome, leptin signaling, and insulin sensitivity can be dysregulated. These particular disruptions set the stage for various chronic diseases like cardiovascular disease, type 2 diabetes, and potentially even things like Alzheimer's disease. And of course, our interest, food addiction, mood disorders, any kind of addiction. So it seems that inflammation or meta-inflammation is the crux of most of our modern ailments. Today, in part 2, we'd like to unpack this principle of meta-inflammation so that we can find how can we use this information towards treatment. So, are you ready, Dr. Padda?
Yeah, absolutely.
One of the things that you talked quite a lot about in podcast 1 was leptin resistance, how leptin resistance leads to the lack of satiety, increases inflammation, which then leads to the increase in pain. Can you elaborate a little bit more on that and specifically how that might play into obesity and food addiction and even mood disorders?
Yeah, absolutely. So the term leptin resistance is thrown around and people don't understand how it comes about. And I think that's the critical element. Once you understand how you get leptin resistance, then it makes perfect sense. So we all know what insulin resistance is. Insulin resistance occurs when we have too much insulin free floating in our body and it doesn't work like it's supposed to. And our insulin receptors stop functioning and they stop taking up the insulin and they involute and they stop working. And so we end up with ever higher dosages of insulin produced by our pancreas, and we have ever lower response from our cells, and thereby we have less glucose and other proteins and amino acids and things like that entering into our cells. And we call that insulin resistance. And insulin resistance precedes diabetes. And that makes sense to most people. Leptin, on the other hand, is a crazy character. Leptin is produced by our white adipose tissue. It's produced by our fat cells, and it's a marker of fullness. So let's say that I eat some food, and I have a whole bunch of different markers that might get released, like glucagon-like peptide, GLP-1. There are compounds in fat that get released, and they send signaling through the bloodstream to the brain, and it's called leptin. And leptin tells you, hey, stop eating. Let's calm this down. But the problem is, the more fat mass that we have, the greater the proportional production of leptin. So if I have 10 kilograms of fat mass, I have X production. And if I have 20 kilograms of fat mass, I have 2X production. And if I have 40 kilograms of fat mass, I have 4X production. It's a proportional increase. And so this is a problem because as we start to increase our proportional production of leptin, our leptin receptors in our brain no longer listen to it. So the bigger we get, the less we can listen to our satiety signals. And if that was the only problem with leptin, we'd go, yeah, that's fine. So what? Leptin is leptin. And so I just don't know I'm full. That's not the only problem, though. Leptin is one of the most potent inflammatory cytokines that we have, and it triggers the formation of the M1 macrophage. The glial cell goes to the phase 1 status. The alveolar macrophages go to a phase 1 status, and that is an inflammatory status. And that's exactly what we don't want to do. And when we have tons of this leptin floating around, it triggers an inflammatory cascade because it's activating our macrophages. And that's the issue. And that's why when we were looking at patients with COVID, and we remember that a lot of the patients with COVID had severe pulmonary disease. And it also turned out to be they had hyperleptin. And they also happened to be the biggest patients in the ICU. And so that was the issue. They were hyperleptin. They had a inflammatory milieu from the leptin, which is the potent cytokine, and they were primed already to have alveolar damage. And so when they did get viral infections, when they did get other issues that occurred, they already had basement cell leakage there, and they also had fuzzy brains. They ended up having glial cell problems. It goes not just there, but it goes through your whole body. It goes to your joints. It goes to your elbow joint. It goes to your knee joint. It goes to your hip joint. Everywhere where you have a white cell, it gets activated. And that's the blood response. Now, what's also interesting is that and we haven't really talked about this, but there's an entire other pathway, and that's through the vagal nerve. Each group of fat cells is innervated, and we have afferent information that's transmitted from these fat cells around our belly, and it goes into the vagus nerve and up to our brain. And it also is supposed to tell us that we're full. But when we have too many fat cells, we lose that capacity. So we're not able to transmit the data up like we want to. And the vagus nerve also transmits data back down. And when it fails to transmit correctly, it changes the gut microbiome. And when it changes that gut microbiome, interestingly enough, it changes how the macrophages and all of the bacteria work in the vessel, in the wall of the lumen, and it causes leaky gut. Okay. And multiple things that are going on.
I'd like to go back. Would it be accurate to say that the more white adipose tissue you have, the more inflamed you are, regardless of anything else?
Yeah, just because you're going to have a higher leptin proportionally.
Exactly. Okay.
And so the greater your fat mass is, the greater your leptin is. It's a proportional increase. And if you get to a critical point, you become leptin resistant. And then it really ramps up from there.
That's the beginning of the spiral onwards.
Correct.
So what can we do with leptin resistance? Is there something that can be done dietary-wise? Because I don't think there's medication for it.
There isn't. We've tried a variety of medications. In fact, the early studies were that we showed that in normal patients, in normal rat patients, we could give them leptin and it would make them stop eating. But if you took an obese rat patient and you gave that obese rat leptin, it didn't do anything. It's because they became resistant. The receptors became resistant. We don't have a medication that works on a leptin receptor. The medication that works on this whole concept is to reduce your adipose tissue. It's to reduce the total fat mass. And so that would be things like intermittent fasting. That would be time-restricted nutrition. That would be all of the other things that we're doing to bring our weight down to normal to reduce our fat mass.
Is there a dietary, aside from eating low carb or intermittent fasting, are there specific foods that might help?
There's not a specific food that we found. There's not anything that we found that preferentially decreases leptin production in the white adipose tissue. And we haven't found anything that improves leptin sensitization in the brain. There's nothing out there that we've got. What's nice, though, is given a short period of time, relatively short, like 72 hours, you can get leptin sensitive again. It's pretty easy.
Could you also recreate that so you had said, obviously, like fasting or time restricted eating, but we often have clients who, when they engage in those behaviors, then the binge aspect of things can show up. And so we try to not encourage that because binging is obviously not healthy for anybody either. And so is it possible to regain leptin sensitivity by just having timed contained meals, even if there were 3 across the span of a day?
Yeah. Oh, yeah. Your whole point of that is to decrease your white adipose tissue. And so leptin is produced post meal after consumption in proportion to fat mass. So let's say that you had a meal, you get a burst of leptin, and that's when it's produced. And so if you have 2 or 3 meals, it's produced each time. The issue is not the production of leptin. It's not that we want to produce more of it. What we want to do is we want the brain to know that leptin is being produced. And so the sensitization there has to be done. So what are the things that we can do to help general neurologic health? Because there is the pathway that we've got for that. And we've got that pathway for insulin receptors. We've got that pathway for a whole host of things. The reason why you get leptin resistant and insulin resistant for the insulin component is there's a lipid raft that these insulin receptors live on. And they involute, they go inward, and they no longer are presenting to the serum or to the extracellular fluid, so that they can no longer task to see the incoming insulin. Very similar outcome in the brain with these leptin receptors. One of the things that you can do is you can improve the cell layers that are there, and those are mostly lipid. Those are high quality lipids. The reason why we are more likely to get leptin resistance and insulin resistance is if the fat that we're consuming is not fluid. And that would be fat that's more omega-6 versus omega-3. Omega-6 tends to stack, and it also quickly becomes a trans fat exposed to fluorescent light. So vegetable oil exposed to fluorescent light is already going to have cross-linking and be a trans fat by the time that you get it into your body. If you got it from the grocery store, it's going to have sat under fluorescent light. Use it once or twice with a little bit of heat, it becomes a trans fat. And so you're not going to be able to tell that it's rotted. You can't tell that it's becoming a trans fat. And so when it gets into the cell wall, you lose the fluidity of the cell wall. And then the receptors don't open and close like they're supposed to. And then they quickly get overwhelmed. So what we do to get patients more leptin sensitive is main goal is to lower the fat mass. The secondary thing is to make their receptors overall more functional. And that's the whole purpose of really giving these patients omega-3 fish oil or krill oil. That's a way around and improves the sensitivity. And it does it in real time.
Okay, so summarize, it's not actually the amount of leptin, it's the fact that we're either sensitive or not sensitive to it. If we do the fasting or intermittent fasting or in any way that my body fat mass, my white adipose tissue, that's one way. And then the second way is dietary by ingesting more omega-3 versus omega-6.
Correct.
Okay.
But now let's go back though. So insulin has its issues. Leptin's independent issue is that it's a potent inflammatory cytokine.
Yeah.
It's a potent cytokine. And so the more you have, the more that it floats in your bloodstream, the more inflamed you are in general.
Right.
And you know that these patients are leptin resistant because they hurt everywhere. They hurt over their whole body.
Okay, good. That's the leptin story. Now, you mentioned the vagus nerve. Can you tell us a little bit more about that? You connected that with insulin. Tell us the vagus and leptin story.
So the problem with obesity is it's a complex adaptive system.
Yeah.
I could probably map out 2,000 different pathways that we've got that all lead to obesity because historically, the human population has been designed to live in famine state. That's our entire biology. We're designed to be creatures that live very frugally. And if we get too much food in front of us, we eat it. And so we're designed to consume as much resource as we can because we're genetically designed to live in a frugal state. That's just something to keep in mind. So all of our systems are designed that if we're given enough resources, we will overconsume them. And if we trick our bodies into it, we'll definitely overconsume them. So let's talk about, that's why there's so many different pathways. That's why I end up going so far into these deep, dark places and talking about particular things, because for one person, it might be leptin. For another person, it might be insulin. For a third person, it might be a glutamate problem. For another person, it could be a tyrosine hydroxylase problem and not enough. For another person, it could be leaky gut. The vagus nerve is one of these things. It could be. Vagal nerve it's the thing that connects our primary brain, which is our brain in our intestines. That's our primary brain. Our primary brain lives in our abdomen, okay? We didn't have creatures that started off with brains up in their heads. How would they know what to do? So the primary brain is the anemone brain that's in our gut. It's the worm brain that's in our gut. And it picks up, if you look at the intestine, you open it up and you look at inside out, the inside of the intestine is really exposed to the outside of the world. It's just an inside out tube. And it has villi, and it just looks just like an anemone in places. That is our primary brain. It grabs food, it absorbs food, it brings it into the system, and it distributes those nutrients. It connects to the main brain through blood. It connects to the main brain through an electrical system. That electrical system is the vagus nerve, primarily. The vagus nerve gathers signals and feeds information to the rest of the brain that tells it, hey, I just ate. I'm going to start triggering this response. I'm going to trigger that response. The vagus nerve controls our heart rate. It controls our respiration. It controls a combination of parasympathetic information, which is our calming information, and it interacts with our sympathetic nervous system. So it tells us when we're in a flight or fright mode, it's okay, we can calm down. It allows us to have all of the things that we think of as in terms of anxiety. It allows us to have sleep. It allows us to change our heart rate and change our heart rate variability. So it's a constant feedback from this primary brain that's in our gut to the main brain that's in our head. It's bidirectional. So it's not just from our intestine to our head, it's also from our head to our intestine. We can pick it up at the level of the ear. And so we can do an ear stim. And we do this all the time. We have part of my pain centers, we tag on to the vagus nerve at the level of the ear, and we can stimulate it. And I can stimulate it with different electrical current, just cutaneously, transcutaneous. And I can put a signal in there that makes you want to quit eating. I can put a signal in there that goes to your head and it makes you feel calm. I can put a signal in there that goes down to your intestines and sends a signal to your intestinal wall, and it changes your gut microbiome in real time because it makes a change in mucus in the gut microbiome, in the wall of the stomach or in the wall of the intestine, the small intestine. And we can radically change the bacteria that live down there. And remember, the gut microbiome changes every few minutes anyway, based upon your mood, because it's vagally driven. It changes based upon the presentation of nutrients that are getting in there. So there's a whole host of things, but we can directly get to it by stimulating the vagus nerve. You can do it at the neck level or you can do it at the brain level. PTSD is one of the things that we treat with vagal nerve stims, and it gives you almost immediate symptom control. But how it's doing it is it's sending a signal to the brain and it's sending a signal to the gut, and it's changing the gut bacteria, which then allow a change in the bacteria, which allow a change in the absorption of different compounds. Certain bacteria take up GABA-aminobutyric acid, which is an inhibitory neurotransmitter. And for my patients, what I do is if they really have problems with sleep, if they are addicted to sleep aids, if they're addicted to Valium or benzodiazepines, or even those that have been addicted to alcohol, I supplement them with GABA and restore their gut health and pre-feed those bacteria. And that's a inhibitory neurotransmitter that then sets up a nidus of brand new bacteria down there. And that will calm the vagus nerve. So I know it gets complicated because it is complicated, but there's a lot of different pathways that are flowing back and forth.
So one of the things that we struggle with is the concept of volume addiction, just needing to be full is in itself a drive to eat, to overeat. Could you explain that through this vagal nerve?
Yeah, let's back up one step. There's a drug on the market. It's called Ozempic or Mounjaro. It's a GLP, glucagon-like peptide. And its primary action, it has about 5 or 6 things that it does. Yeah. But the primary action that we're using it for currently is it causes gastroparesis. It prevents your stomach from emptying. And when you have that, you have a feeling of fullness. And instantaneously, you stop eating because you go, oh my God, I can't eat anymore. I'm full. And so that GLP-1, that's how it works. Now, it has some other actions, and we can talk about them. But the primary action is that GLP-1. Now, what's interesting is the vagal nerve, if you stimulate it, it also causes GLP to get released. And it also works in the brain where the GLP goes to work also. And so it'll do both. It'll really help. Now, I do want to, and I hate to do this to you, but I do want to mention a few things about Ozempic that are interesting, that are emerging, because everybody uses GLPs, and I don't think that they realize what they do. And so this is my bent, but it's well proven. So this isn't something that I'm cooking up in the garage.
We're open to it.
GLPs cause gastroparesis. They prevent you from emptying your stomach, so you feel full, so you don't want to eat. GLPs, because they do that, they change the secretion of acid, and your pH changes. Your normal pH in your stomach is about 2. It's very acidic. So when you eat food, when you eat protein, it denatures in your stomach, and it also kills the bacteria that are coming in with the food that you're eating because it's so acidic. And once you kill those bacteria, the food migrates forward into the small intestine. And hopefully, if you have a not too permeable small intestine, you don't get a bacterial load and lipopolysaccharide that floats into your bloodstream, and you don't get complications from LPS. But what happens when you have a GLP is your pH goes up. So you're no longer killing the bacteria that are in your stomach, that are coming in with your food. And you're no longer able to denature the protein that you're getting. So you can't get amino acids to break down. You get half digested food in your small intestine and you can't break it down. You can't also absorb it. And if you can't absorb it, you get sarcopenic wasting. You get
muscle loss.
And so you lose muscle before you lose fat, and you never regain that muscle. It takes 6 weeks to 12 weeks to regain muscle after you've lost it for 1 week. And that's if you exercise. And what's happening is when you put patients on GLPs, they're not regaining their muscle mass after they lose it. So a year later, when you take them off of a GLP, they've gotten to a decent weight, but they got there because now they're skinny fat and they've lost their muscle mass, which then muscle is the organ of longevity because there's no myokines being produced, and they have a more likelihood of fall and break and get osteoporosis and those complications. There's another action, and this goes to the heart of GLPs, and it goes to the heart of vagal nerve stem. Remember, vagal nerve stem affects the dopaminergic center in the brain. It makes you feel calm. It reduces your PTSD. It gives you a little dopamine release. So do GLPs, and they actually cause you to get a little anhedonic. You don't really want to do anything. And it's such to the point that some patients who are imbalanced slightly have a higher suicide rate. And there's a 35 to 45% increased rate of suicidality. And I think that's going to be a big deal going forward. And I've got patients who were alcoholics. You put them on the GLP, and all of a sudden they stop drinking and they start seizing because I didn't know how much alcohol they had been taking in. They start seizing. So these are all factors that are of significance.
Meds have been pulled because of suicidality risk. Like the cannabis-based one in the 1990s got pulled because there was a higher rate of suicide. Can you imagine if that happens with the GLP-1s?
Yeah, I don't think they're going to pull them because the companies have gotten pretty sophisticated. So I don't think that they're going to pull this drug. Okay. But I do think that our patients should be aware of this. And if they do get this issue, that we can start treating it and figure it out. And even the muscle loss issue is manageable if you do it right. So how do you manage that? How do you prevent that from happening? What I do is I give my patients leucine. Now, I don't use a lot of GLPs. So let's start with that. I've used them, and they're a good bridge, just like I would use Suboxone as a harm reduction tool. I certainly agree that harm reduction says that GLPs work. But what I do is I give them leucine or isoleucine, and that improves their muscle mass.
And that is a nutrient or a supplement?
It's an amino acid. It's just a supplement. Okay. And it's very cheap. It's very inexpensive. And it's basically pre-digested protein. It's branched chain amino acids. Tastes bitter as hell. It's just disgusting. But bodybuilders use it all the time, and we give it to our patients. That's one of the tools that we use sometimes.
You mentioned something circling back to, you mentioned stimulation of the vagal nerve through ear or neck. Is that something that we can use as clinicians with our clients to support?
Yeah, right now.
The vagal nerve?
There's a stimulator called the NS100, and we work with patients all the time. It's approved for these 3 indications: PTSD, neuropathy, addiction. And it's getting approved, hopefully, as another method for weight reduction, because it seems to work pretty effectively, and it doesn't have the suicidality as much.
So you could use something like that, get your natural GLP-1 optimized, and then therefore not crave more food.
Yeah, exactly. I think that's these combination therapies are emerging. We didn't have a great system for vagal nerve stim until probably 3 or 4 years ago. We've always had these transcutaneous stimulators that you put on your neck, but you really couldn't hold them there. And so a few years ago, the Food and Drug Administration approved a auricular stim. And it's basically electrodes that you put onto the ear, 3 electrodes, and they stay on there for about 21 days. And there's a drop of super glue they put on them and then a clear dressing. And it runs continuously based upon what you need it for 21 days. And the effect of it lasts far longer than the 21 days. Once you've stimulated the vagus nerve, it retrains the vagus nerve. And we know that it's changing the gut microbiome. And so that effect lasts for a year plus after you take it off at 21 days.
What about more traditional vagal nerve stimulations like deep breathing, yoga, meditation?
They all work. Yeah, absolutely. And in fact, if you have an Apple Watch, there's an app on your Apple Watch. It's called Breathe, and it shows you what your heart rate variability is. I have my patients frequently who have PTSD or severe anxiety. We have them do box breathing. And the biofeedback that they can use is their Apple Watch. They can look at the number of milliseconds, and it tells you what your heart rate variability is. And you want to expand your heart rate variability. And you get a direct response day to day looking at that. It's a great feedback loop.
The gut biome, you've already mentioned it, but you talked about it's the primary brain essentially, and that the vagal nerve is the highway between the gut and the brain. You mentioned something about GABA production, leaky gut, which of course the processed foods will disrupt. If you could just elaborate a little bit more on that and what are some solutions?
Yeah, a lot of folks talk about, oh, so-and-so has small intestinal bacterial overgrowth, or SIBO. And SIBO is a concept of wrong bacteria at the wrong place in your small intestine. And if that's true, if you have SIBO, you produce an excess amount of methane and hydrogen based upon the fuel source that you've taken in, usually an insoluble fiber. The way you test yourself is to take in some inulin and then measure your exhaled methane and exhaled hydrogen. There's at-home tools that you can use to figure that out. There's a little device that you breathe into, and it tells you exactly how much hydrogen and methane you're breathing out. And it's probably about $200, but you can use it for years because it's a tool that you can carry with you. So if you have chronic abdominal pain and bloating intermittently with food, you might have SIBO. It's interesting because these bacterial overgrowths occur for a whole host of reasons. One of them is exposure to antibiotics. So if I gave you a dose of antibiotics, it would change your gut microbiome potentially for about 3 years, a single dose. And it might take you that long to get it back. One, we can repopulate that gut microbiome. And there are yogurts and kefirs and things like that we use. What I typically use, there's a doc named Dr. Davis, Davis, I think. And he has a whole protocol on SIBO using Lactobacillus reuteri yogurt.
Yeah.
What's special about it is that it has inulin in it as a prebiotic, and it takes 36 hours to make. It works very quickly. And if it works for you, you probably had SIBO. Right. And any antibiotic can do this to you. An antibiotic in farm animals that you ate could do this. Pepto-Bismol could do this to you. So there's a whole host of things that can affect your gut microbiome. And leaky gut is the concept that if you have abnormal gut microbiome that are populating an area, or you're exposed to certain antigens, the junctions between your cells will break apart, and they will allow fluid and lipopolysaccharide, which is the shells of gram-negative bacteria, to get into your bloodstream. And you're essentially putting stool material from your intestine, from your small intestine, into your bloodstream. It just so happens that lipopolysaccharide cross-reacts with a whole host of nerve tissue and a whole host of bone and joint issues. And so if you have LPS leakage, you'll notice almost immediately that your bones hurt, your joints hurt. You might even notice that you have fuzzy thoughts. You might notice that you just don't feel good. You feel like crap. And so that's one of the factors. There's an entire other factor. If you look at, there's areas they're called Peyer's patches. And Peyer's patches are areas of basically immune cells that live in the intestinal walls. They live in your gut, and they have a lot of immune cells in them. And that's what the if you took something in and you weren't supposed to eat it, and it has an antigen that you're not supposed to have, or your body thinks it's a parasite, it's going to go past one of these Peyer's patches and the white cells are going to react to it. It just so happens that those Peyer's patches directly interact with our dopamine system. And so if we have leaky gut and our Peyer's patches are hyperinflamed, we immediately, through the vagus nerve transmission, will start to decrease the amount of dopamine. And we'll start to feel like crap.
Yeah.
And so and start craving, because what we're trying to do is we're trying to do hedonic substitution. Yeah. Because we're like, hey, I just don't feel good. One, my bones and joints hurt. And two, I just don't feel good. And what can I do? What can I do? And so people start to crave narcotics and they start to crave food because they do hedonic substitution. And there's a whole host of other things that happen, but there's a direct interaction between the dopamine receptors in our gut and the dopamine that's produced and the vagus nerve transmission and what happens in our brain. And so there's a direct demand that occurs in the presence of leaky gut through the Peyer's patches. And there's at least, I could probably come up with 30 other pathways that are immune related in the intestine that are similar. GABA aminobutyric acid, is one of the things I mentioned. It's an inhibitory neurotransmitter. There's two major inhibitory neurotransmitters, and there's some excitatory ones. Glutamate is an excitatory one. Let me start with glutamate first, because I think there's a little bit of thing that people don't realize about glutamate. Glutamate is, we think of monosodium glutamate.
Yeah, MSG.
MSG. Yeah. And we think the food label says there's no MSG in this food. But did you know that they could put up to 450 milligrams per serving of glutamate in your food per serving, and they don't have to put it on the food label? And you might be sensitive to 5 or 10 milligrams, and they can put 450 in there. So that's the problem. So we don't know if the food label is telling us accurately if there's glutamate in there or not. Glutamate was originally used in food for two factors. One was it prevented us from figuring out if food was rotted, because our body, our taste buds, when we get glutamate, it works adjacent to the dopamine receptor, and it makes it think that it's more pleasurable than it is. It's an excitotoxic neurotransmitter in the brain, and it's an excitotoxic neurotransmitter everywhere in our body. If we put glutamate on a nerve cell, we can cause an acute degeneration of the cell. We can cause the cell to rupture because it activates the NMDA receptor. It's not the rotting food that creates the craving. It's they added glutamate. Yeah. The thing is, the rotting food we don't want to eat. No. We can eat it, but we don't necessarily want to eat it. But if you add some glutamate to it, it makes it more pleasurable than we would normally expect. So when you end up with a giant serving of Chinese food, because that's MSG is one of the common elements in processed Chinese food, you end up eating a ridiculous amount of glutamate. And it tastes so good. Originally in the United States, the Chinese restaurants would add it because they weren't using the freshest of meat. They weren't using that today meat. They were using what they could get in the market. And it might be a few days old. It might be 2 weeks old. And there was no way to tell, because our taste buds didn't tell us it was rotted. They didn't tell us that it was starting to go bad. Inhibitory neurotransmitters, glycine and GABA aminobutyric acid, calm down our nervous system. And when we're exposed to them, they make us sleepy. And so,
and just for people who don't know, that's the basis of alcohol and Valium and the benzodiazepines.
It's another way to make your brain start to feel unwound and sleepy. And so what we do in our patients to get them off of the benzodiazepines is we substitute the benzodiazepine over time with GABA. And what you want to do is improve the number of bacteria in the gut that process things to GABA, that allow you to absorb GABA more efficiently. And I find a lot of my PTSD patients and a lot of my benzodiazepine-dependent patients have tremendous response.
You don't mean gabapentin, the pill, just for folks listening. You mean GABA, the supplement, right?
GABA, the amino acid GABA.
Are there foods that have a higher amount of GABA?
There are. I haven't gone down that road just because a lot of them are calorie dense. And so what I want to do is I want to give people GABA at the end of the day. I have a protocol for sleep for people that have severe sleep disturbance. We deal a lot with PTSD. So we have a sleep hygiene protocol. And part of that is we use everything in our spectrum, everything from put somebody into a cold room with a background noise, pitch dark, GABA supplement before, put them into a sauna an hour before. And what it does is it heats up the shell of their body, but it cools their core. So it starts getting them ready for sleep. So these are all just peripheral things that you can do, but they do have significant impact. And GABA, when you take it for about 4 to 6 weeks, 4 to 8 weeks, your own intrinsic bacteria start to shift and they start to train themselves to produce more GABA cyclically. I tend not to use much melatonin for my patients. I think that's a dangerous drug. It's only really been tested in humans up to a dose of about 3 milligrams.
And we prescribe 10 milligrams, sometimes about 20 milligrams.
And what happens with melatonin is it's a very potent endocrine inhibitor. And so it has more effect than just the fact that you're going to get some melatonin at night. It can have a paradoxical effect. It can really screw up your endocrine system. And so I let patients have up to a milligram, even up to 2 milligrams, maybe 3, but I try to get them away from melatonin. And what we do is we want to maximize their production of melatonin by having good sun exposure during the daytime and then not having any exposure to blue light about an hour, 2 hours before bed. And so that will allow that'll allow the brain to release the melatonin that we want.
It screws up the endocrine system. So are we talking things like leptin and ghrelin?
No, I'm talking more things like testosterone and estrogen. It screws up your hypothalamus.
To summarize, it sounds like we want to eat foods that are high in omega-3, that you want to maximize your sleep in the way that you've described. I'm assuming exercise fits in there somehow. Avoid processed foods.
My summary is, look, I want you to move after every meal. I don't care what you do. I want your quads working. And so after every time you eat, I want you moving. And I want to get those myokines working. And I want to retrain, especially your quad muscles, to make you more insulin sensitive. I want to minimize your carbohydrate dosing. And that is as low as you can possibly go. For me, low carb is less than 20 grams a day. And I've got patients that are on 5 or 10 grams. And so I want to really minimize that. I want to maximize the protein consumption that people have. And for me, that's more than 1.5 grams per pound of protein. The studies that we've done in the past that said, it's 1 gram per pound, those studies are basically bare minimum studies. I want to maximize the amount of protein. I want to eliminate the vegetable oil as best as I can, because I'm already going to get some omega-6 in everything that we eat. So I want to minimize that. I want to not have processed food, because in the processed food, they're going to hide things that you're not aware of. You're not going to even know that you got the glutamate. You're not going to know that they made each Dorito taste different, and you don't have sensory specific satiety. So I also encourage patients not to have 6 different kinds of food. If you can just do those few things, you're well on your way. And then there are other things. You can change the timing of eating. You can change the exact foods that you eat. There's a whole host of other things. But if you start with those simple things, move, get rid of the vegetable oil, get rid of the sugar, eat to satiety, don't eat processed food. If you can do that, you're 80-90% of the way home.
Yeah, you're going to resolve the leptin resistance. You're going to heal the microbiome, right? You'll optimize the vagus nerve.
Yeah, absolutely. And you'll start reducing your inflammation. And that'll be the domino series that starts getting you into the right direction. And then if you have other medical issues, like you do have SIBO, then we've got protocols for that. We've got ways to get around that. There's a whole host of things that go wrong with people. And you can have something subtle, like you might be on a supplement that has titanium dioxide in it. It's the thing that makes pills white. And that titanium dioxide causes you to get leaky gut. Not everybody, but some people. And so there's so many different pathways. You might be somebody that does mouthwash every morning. You don't even realize it, but the mouthwash is killing the bacteria that metabolize arginine and citrulline in your tongue. So your nitric oxide is low. And that might explain half the problems. So literally, we're such a complex adaptive system that we start with the general, and then we narrow it down from there, trying to figure out, okay, what about this patient is different? Okay. And that's why this isn't going to be solved with Ozempic. This isn't, You're taking some Ozempic is not going to solve this problem.
It's so complicated. How do you handle the person when they walk in, when there's so many things that it could be? But you're saying you would start with those basics, and then as the person progresses or doesn't progress, then you try to puzzle it out.
You have to take them where they're at and then look at them within the paradigm of where they're at.
Okay.
I mean, what happens if the patient has a PTSD? What happens if the patient has, if they've been sex trafficked? I see this twice a week, 3 times a week. What happens if they lost their parents when they were young? There's so much psychological and psychiatric overlay that you don't know till you get into it. And so that's the problem with this area. That's why there's people like you, Vera, that are spending time with patients or they're spending time thinking about this. It's more than just take this pill and move along. If it was that simple, we would have fixed obesity 40 years ago. And so it's not that simple. Now, what's happened is so sometimes it's better to look at what happened that got us here in the first place. What primarily happened was our vegetable oil consumption went way high and our processed food industries really kicked into high gear. And when we got rid of smoking, all of those smoking scientists go over to the food industry.
Exactly. And
addiction.
And the problem is we do think we have a solution now. Ozempic, all of this discussion is in the background because Ozempic is in the foreground. So what do you do when you have somebody come in and they say, I'm on Ozempic? That's going to mess up your complex system, right? What about antidepressants, on other medications? What do we do?
So it's interesting. I just had a long discussion yesterday with a psychiatric residency. I was doing a lecture series for them. And it was specifically on managing addiction in the psychiatric population. And it is complicated. And so you really do have to break these things apart. In psychiatry, what's happening is the medications that we use don't work that well. The reason why they don't work that is because the brain is hyperadaptive. So if I give somebody an antidepressant,
tolerance,
that depressant stops working because the brain gets used to it really quickly and it goes, I don't need that. Or it overwhelms the brain, and then it just loses the receptors and then it doesn't work anyway.
Somebody comes in and they are on Ozempic, and on its own, it's going to stop working and create protein loss. And how can we work with them?
So what I do is I give them leucine. Yes. I give them leucine supplementation because what I want to do is I want to trigger the formation of muscle. And then I go down the pathway of, can this person exercise or not? Can they get any exercise? Right. Can I create muscle shearing so that they will regrow muscle? That's what I'm trying to do. I'm trying to create a shear force in muscle that triggers the muscle to regrow. And if I can do that, it will reformat itself and it'll grow bigger and it'll produce more myokines, and myokines are beneficial to me. Okay. And it increases your basal metabolic rate. If you just lose weight, your BMR starts to drop. If you lose muscle mass, your BMR drops a lot more. And so that's one of the problems. The less you eat, and the less you need to eat. I want to get the muscle mass back up, and I can drive the BMR back up and maintain that.
What about somebody who comes in and they're on Seroquel or quetiapine or one of these medications that actually creates insulin resistance? What do you do there?
We try to wean it off.
That's basically it.
And that's it. What you got to do is you got to go back and figure out, why are you on Seroquel? And how long have you been on it? And does it still work for you?
Okay.
And you substitute it in some way so that you can get them off of it. You don't have I find that the vast majority of patients, you're able to wean off. It might take you 3 months, might take you 6 months. Benzos are some of the hardest to wean off. It might take you 6 months plus. But I have a lot of patients, you can get down the first 70 to 80% of their benzodiazepine, but that last 15, 20% might take you 6 months to get them off.
Okay.
You got to give them harm reduction, because if you don't give them a replacement, you're in trouble.
I have one more question. Yeah. You mentioned the concept of metabolic memory. Does that imply that even if you get your food back on order, you're eating well, you've got your leptin resistance resolved, et cetera, that there's still some kind of residual memory that will pull you back to your previous ill health?
Yeah, it'll last for a good year or two. It's not something it's not permanent, but you do have some significant changes. And it's not just metabolic memory in you. It's a significant epigenetic change, and it's transmittable. So we get metabolic memory transmitted from the mother to the child, because you've changed the egg and you've changed all the DNA in the egg, and you've changed the methylation of the DNA. And so you get a transmission of information in that way. So that metabolic memory will last in you for a couple of years. And it may be what you give to your child right when they're first born. They may be inheriting that metabolic memory. Now, they're also going to inherit the gut microbiome. They're going to inherit everything in their environment. It's a very interesting thing because I work in a center that's an interventional pain center, and I'm working with patients that are metabolically ill, and they're coming in with their microbiome surrounding them, and I'm shaking their hand, and we're doing procedures, and I'm breathing the air. I'm picking up the working hazard that I have is that I'm picking up their gut microbiome, their airborne microbiome constantly. And so when they're sick, there's a good possibility that not just that I might get an upper respiratory tract illness, but I might inherit some of their microbiome just being in the same room. And that's an occupational hazard. So you have to think about that a little bit as in terms of being a physician.
Wow. Amazing. Amazing. We want to be really respectful of your time. We have 2 closing questions for
absolutely.
you. Yeah. So first is, what's next for you?
This thing with metabolic health, I think what we measure, we manage. If we don't measure it, we don't manage it. It's the concept of Deming and the Hawthorne electric effect. If you measure something, you can fix it. And if you don't measure it, you can't fix it. So we're coming up with tools that give feedback to patients in real time that will let them know what their metabolic health status is. And we've developed an AI with metabolic tools that gives that feedback in real time, and they can easily get the information in less than 20 minutes. And it gives us hazard ratios as in terms of likelihood of outcome over the next 5 years. So it tells me things like normally if you had coronary artery disease, you would do a cardiac cath. That's very invasive. Maybe I can do a CAC score, coronary artery calcium score. But hold on, once I get the calcium in my coronary artery, it doesn't really change and my CAC score is always high. And if I got better, how do I know? So we've come up with tools that change as the body changes. And one of the most sensitive indicators is plethysmography. It's nitric oxide production. And it's insulin resistance. And it's not hemoglobin A1C because that underrepresents insulin resistance, but things like LPIR. So aggregating these tools together gives us hazard ratios that are highly sensitive and specific. And then it allows us to feed back to that patient lifestyle changes that they can implement. So we created an AI to do that. It's called Measura.ai.
Is it available now?
Yeah, we're doing it. We've rolled it out into about 54 practices, and it's working. And so we're working with clinicians that are interested in this field. And frankly, I was surprised. Our number one folks that are interested, it wasn't who I thought it would be. It turns out to be orthopedic surgeons. And you might ask why. Yeah. And the reason why is that per 1,000 patients that they operate on, there's 8,000 patients that they don't operate on because they're metabolically sick. And so they kick them out of their practice going, I can't operate on you. I can't do anything for you. And so they need these patients to get metabolically healthy so they can replace the hip or knee. And so they need that done as fast and as efficiently as possible so they can get procedure. Otherwise, the problem is the patient can't even move. And so I was surprised, but that was the first group of people that said, hey, we really need this. And so we were able to implement it. And we're in the mid-50s practices. And we think that long-term, it'll have a significant impact. That's one area of heavy focus for me right now. We developed it in-house, this AI that's just amazing. And it works pretty well.
Excellent. We'll look forward to hearing more about that. We have a signature question we ask everybody. We tailor it to our guests. So if you could tell a younger version of yourself something about omega-6 or chronic inflammation or food addiction, what would that be?
If I was telling my younger self, I would actually tell myself to not eat processed food. I used to eat the crappiest shit from the hospitals. And I would just ravage myself eating French fries. I had no idea what they were doing to me. And what's interesting is I went down the rabbit hole of not even thinking that nutrition was that important because I never got educated on it at the beginning. And it was an afterthought. And it's only when I realized, hold on, my patients are sick and they're getting bigger and they're getting more addicted and they're getting worse rather than better. And I've gotten to the cause of their pain, but I'm not able to fix it. And so that's when I figured that out. It made a huge difference. I wish I'd recognized that a lot earlier. I'm convinced that probably 3/4 of the disease processes that we have in the United States are metabolic. If we can fix that, we probably save about $1.3 trillion to $1.7 trillion a year. And we eliminate a bunch of suffering. And it also means that about half of our hospitals close. It also means that most of our pharmaceutical companies close.
Yes.
It also means we have a healthier population that's more productive and less people on disability. So I wish I'd figured that out before. I think we're there now, though. I think that we're about to see some radical changes. And I think that we're about to see a paradigm shift. I think everybody's coming to the same conclusion that what's driving our ill health is a metabolic issue. I don't think that's unique anymore.
I think that's a very optimistic way to end our podcast. Thank you so much, Dr. Padda, for sharing your insights.
Sure, absolutely. Hopefully I didn't go down too many rabbit holes.
All right. Thank you.
Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group. I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.